Evaluation of renal function is very important in clinical settings to monitor the health of the kidneys. Although urinalysis provides very valuable clues about renal function, a more complete assessment can be provided by measuring the rate at which the kidneys remove a substance from the blood. And this is a process known as renal clearance. Renal clearance and GFR both are measured in the same units, milliliters or a volume of plasma per minute. For a substance to provide an accurate measurement of renal clearance and the GFR, the substance should be completely filtered, completely, and neither resorbed or secreted, right? Just filtered out the glomerulus into the filtrate, and that's it, doesn't get adjusted. Substances secreted by renal tubules have a renal clearance that is greater than their GFR, whereas those that are reabsorbed have a renal clearance that is less than their GFR. So, to measure renal clearance, we have a limited group of substances from which we can choose, and they all make estimates, you know. But two such commonly used substances, or one that you make just normally, which is creatinine. And then there's another one that we can use that's a chemical we can introduce to your body and see how it's filtered. Creatinine, as you learned before, it's a waste product of the metabolism of muscle and pretty much all your other cells. Nearly all of the creatinine produced is excreted by your kidneys. Nearly. When the kidneys are impaired, the level of creatinine in your blood tends to rise. Creatinine excretion can then be used to estimate GFR, and we can do this by comparing the amount of creatinine excreted in your urine compared to the plasma concentration of the creatinine. I mean, yes, we can do that, right? But the main difficulty with using creatinine as an indicator of glomerular filtration is that it's not true that it's not reabsorbed or secreted. Anywhere between 15 and 50% of creatinine in your urine arrives there by secretion, not filtration. So, a patient with a very low GFR may still have a nearly normal result from a renal clearance test with creatinine. A more accurate assessment of the GFR can be obtained using substances like inulin. Inulin, which is not to be confused with the hormone insulin. Inulin is a complex carbohydrate found in plants like garlic and artichokes. And inulin is freely filtered by the glomerulus. It doesn't keep any of it. But inulin, it's neither reabsorbed nor secreted by the renal tubule or the collecting system. And this means that the GFR measured by inulin, we can inject you with inulin and then compare your rate of excretion to your plasma concentration. And this is a much more accurate way to measure renal clearance than just assessing creatinine. Renal clearance and a concept called transport maximum are closely related concepts, and they both help explain how substances are handled in the kidney. Renal clearance refers to the volume of plasma from which a substance is completely removed per unit of time, and our unit is 1 minute. Transport maximum, on the other hand, is the maximum rate at which a substance can be reabsorbed by the renal tubule. So it's a lot more specific. It's just about the reabsorption. When the amount of a substance in the blood is below transport maximum, it can be fully resorbed, and its clearance is very low. You can take all of it back. But once the filtered load exceeds the transport maximum, the excess remains in the urine, and the clearance increases. I want you to think about this equation up at the top and think of yourself as the filtrate. You are first being formed in the glomerulus by way of filtration. And you want me to say that anything that gets into the filtrate will be removed with the urine. And we know that that's false because there's reabsorption. Reabsorption can take things away from that filtrate. And that's why it's a negative value in this equation. But balancing things again, there's also secretion, which is like secretion and glomerular filtration work together. So, like, secretion can add things to the filtrate, and that's why it's a positive value in this equation. Filtration and secretion contribute to putting things into your urine, while reabsorption takes it back. Let's consider the renal clearance of glucose. You keep all the glucose that you possibly can because your body contains DNA that remembers a time when food was scarce for the human race and is always expecting the next famine, and therefore you are always keeping all the glucose you can. So the renal clearance of glucose is low because you're always keeping it. You have retained the substance. You have reabsorbed the substance. There is not a lot of substance in your urine. There is not a lot of it. There is a lot of it in your blood plasma. But I mean, I can never really know your values of reabsorption or secretion, right? I don't have like a thermometer or something that I can stick into your kidney and know that. But there's a quick and easy reference that we can make by comparing GFR and renal clearance. If GFR is greater than renal clearance, which is the case with glucose, the substance is reabsorbed and there's very little of it in your urine. If the GFR is larger than the renal clearance, the substance is being secreted and there's a whole lot of it in your urine. All right, so let's extend this example of glucose to help us understand transport maximum. Normally, all of your filtered glucose, everything that makes it into the filtrate and that renal capsule, is just immediately reabsorbed in the proximal convoluted tubule. Right? So glucose, its clearance is essentially zero. You're always keeping as much as you can. However, if blood glucose levels rise significantly, such as in uncontrolled diabetes mellitus or the consumption of an entire cheesecake, and I'm telling you this from personal experience, the filtered load of glucose exceeds the little transporters in the PCT that are trying to take it all back. They want it all, but there's only so many of them. So once that transport max is surpassed, which is around 375 milligrams per minute in healthy adults, once that transport max is passed, the transporters become what we call saturated, and they just can't move more glucose even if they wanted to. That's like the point that you're at when I say, could you study more? And you're like, Amy, there is no way I could study more even if I wanted to. So at this point, excess glucose appears in your urine. And at this point, glucose clearance increases from zero to a positive value. It doesn't matter because it shouldn't be a positive value at all. And this illustrates how renal clearance rises when reabsorption hits its maximum capacity. I have a great example. GLP-1 receptor agonists like semaglutide primarily lower blood glucose by enhancing insulin secretion and slowing gastric emptying. But some of these drugs also reduce the filtered glucose load by lowering plasma glucose levels. So, as a result, since we're below the transport max, glucose levels in the kidney filtrate stay below the transport max of the glucose transporters. And this allows for nearly complete reabsorption and keeping glucose clearance low. In contrast, Invokana, which is a diabetic drug, it is an SGLT2 inhibitor. So it's a glucose transport inhibitor. And it directly targets the transport maximum by blocking the reabsorption of glucose in the proximal convoluted tubule. So even when blood glucose is below the normal transport max, Invokana prevents those transporters from working properly, so more glucose stays in the filtrate and it's excreted in the urine, right? And this is what increases the glucose renal clearance artificially, right? Not because transport max was exceeded. That's not the case. But what Invokana does is it blocks the transporter. So this example illustrates how manipulating the transport max through pharmacokinetics can directly alter the renal clearance to achieve therapeutic effects in conditions like type 2 diabetes.